Welcome, everyone, to another Diabetes Canada healthcare provider webinar. My name is Grace Leader. I'm the manager of healthcare provider education, engagement, and professional membership with Diabetes Canada. And I'm very excited to bring you today's topic of diabetes and disordered eating. Do they inevitably coexist? I'm excited to welcome our speaker today, Jenna Walsh. Jenna completed her undergraduate degree in human nutrition at the University of Guelph in 2008 and her dietetic internship through the Ottawa Hospital in 2009. She's been working as a clinical RD for over 12 years in rural Ontario between long-term care, primary care, and private practice. Her favorite accomplishments include development of Kids in the Kitchen, a 6-week school-based cooking and nutrition program, and more recently, co-development of a 6-week multidisciplinary virtual eating disorder support program. She has been sharing her nutrition knowledge via her online blog and via the North Renfrew Times newspaper, and was awarded the 2021 Best Freelance Column for the Ontario Community Newspapers Association. She presented the 2022 Diabetes Canada Conference in Calgary, Diabetes Canada's Diabetes Frontline Forum, as well as presenter and member of the program scientific committee for the Diabetes Simplified Accredited Program. Outside her private practice, she works part-time between 3 family health teams and long-term care, working to normalize food for all patients and clients. So without further ado, I'll pass it over to you, Jenna.
Thank you so much, Grace. So happy to be here talking about 2 different topics that are near and dear to my heart. So let's go ahead and jump in terms of diabetes and disordered eating. Do they inevitably coexist? So for today, in terms of disclosures, I don't have any to declare. We're going to just quickly go through basics of diabetes and disordered eating overview, some symptom overlap that you may see in clinic, and those red flags that we really want to be looking for, as well as how we can support patients without doing any harm. Now, in terms of objective, really just leaving today with an understanding of how diabetes education can potentially influence the development of disordered eating and vice versa. So sometimes how disordered eating may potentially lead to diabetes or prediabetes, and then looking at some skills to recognize signs and symptoms of disordered eating in people that you're seeing who live with diabetes, and trying to use some screening tools to recognize those symptoms and be able to provide the education that patients may need. So let's just briefly do a quick overview for you that are here watching, very basics in terms of diabetes. We're going to talk about type 1 and type 2. So whether it's insulin resistance, some partial or complete cessation of insulin production, and then key lifestyle contributory factors. So whether it's sleep, stress, diet, if people have had an injury, exercise changes or medication changes. And then on the flip of that, looking at what disordered eating entails. Now, imagine a bit of a spectrum when it comes from disordered eating to a clinically diagnosed eating disorder. We're still looking at disturbed or disrupted eating patterns. That can be anything from restrictive eating, compulsive eating, maybe having rigid or really strong rules around food, and sometimes fear or lack of control. So we're going to look at those 2 pieces together. If we look at current diabetes management, and for the most part from a lifestyle perspective, we're here talking about diet, so very basic standards of education, glycemic index, reducing refined carbohydrates, maybe less takeout, reducing things like pop and juice and treats. Exercise, typically as care providers, we're typically encouraging increased movement. Sleep, luckily, is more on the radar of care providers to ensure there's no sleep apnea present, that people are getting adequate quality and quantity of sleep. We know that can impact blood sugars. Medications, so definitely orals. I would say in the last few years, definitely an increase in terms of discussions around injectables, and then also insulin as well. And stress is a big one. So we can look at these 5 different factors as either, you can think of them as pillars or puzzle pieces, but key players in people's toolbox, if you want, of diabetes management. One piece that's not on here, and this is a big topic for today, is our discussion or focus around weight. We know as care providers, weight is a chronic disease that we want to potentially address with people if it's a factor in their diabetes. And this is a key piece that I really want to highlight. What I mean by this is, if somebody walks in your door with newly diagnosed prediabetes or diabetes, and we check their BMI and recognize that perhaps they're overweight or in the obese range, us telling them that they need to lose weight does a few things. It lays blame in terms of diabetes diagnosis. It also focuses their entire management on the scale. So it takes away from us focusing on, how are you eating? How are things going? What can we do maybe to improve diet if it needs to be improved? With exercise, are you moving enough? What do you enjoy doing? It takes away from that because exercise becomes solely to control weight. Okay, so this is an important piece that I really want to highlight, that weight potentially should be a side effect of us assisting them to manage these lifestyle pillars, not a focus. Now, to completely contradict that, we look at chapter 11 in the guidelines. It flat out highlights that weight loss is the most important and effective dietary strategy for those with prediabetes and recently diagnosed type 2 diabetes. So again, we go back, I'm asking you to put weight kind of to the back burner and focus on these other pillars or puzzle pieces. And let's see why. If we focus more in terms of nutrition education, what do we as care provider focus on, right? We typically talk about processed foods, reducing red meat to make sure that heart health is also at the forefront of care, talking about lower glycemic index foods, maybe increasing veggies, reducing alcohol, especially with the new guidelines. Patients that may be on insulin, we might be taking an even stronger focus on that carb to insulin ratio. And, the whole thing around cooking more at home and eating out less. As care providers, I don't want you thinking, we can't have these conversations. We are hopeful that people that walk in our door with diabetes can reach and achieve these targets, right? They can eat more whole foods. They can eat more veggies. They can cook more at home, maybe have some enjoyment with that. That's the ideal. The piece that we need to ask about, the piece we need to be aware of is that not all people can afford to eat more veggies, or they may not like them. They may have fairly significant food sensory issues. They may not have capacity to cook at home. So there's a lot more to the very basic and hopeful nutrition education. This is a statistics that came out of a study that estimating between 12 and 40% of people with type 2 diabetes have an eating disorder. This is significant. So if you are a diabetes educator or care provider seeing people with diabetes every day, at worst, let's say you see 50 people a month with diabetes. At worst, you're seeing somewhere between that 60 people a year with an eating disorder. Okay. If we're looking closer to 40%, again, we're looking closer to 200 to 240 people a year that have come into your office for diabetes education who are living with an eating disorder. That's a lot. So let's look at what the connection is and where we can see some of those red flags. Now, this schematic I just threw together because I want to acknowledge that depending on the type of diabetes you're seeing, okay, so the disordered eating and diabetes together, break them down into type 1, type 2, we do see a little bit less concrete evidence in type 2. It's a little bit more challenging to track, but we do see higher rates of binge eating disorder and then also restriction and bulimia. Now consider that this relationship can be cyclical and or, what came first, kind of chicken and egg scenario. So we do sometimes see or can see people who live with binge eating disorder first may develop diabetes. Okay, that can be cyclical though, that diagnosis of diabetes can be very triggering and reinforce those disordered eating behaviors. Okay. Now into type 1 diabetes, we typically actually see quite higher rates of diabulimia, meaning patients with type 1 diabetes are restricting insulin in order to control weight. Obviously, the medical concerns there and risks of DKA are quite significant, and it's a very important piece that we need to be screening for. We're going to talk about what we're looking for in clinic. And then we also do see some restrictions. So quite oftentimes in attempts to lose weight, we may see that type 1 who's been eating a fairly varied diet suddenly be on keto or low carb in attempts to reduce insulin use and manage weight. So this study really just looked at type 1 diabetes, and it was over about a decade, and they found that about 25% of people with type 1 diabetes had some form of disordered eating, typically purging and laxative misuse. Now, of about 25% of the people in the study with a history of disordered eating, about 60% of them had a misuse of insulin, so that diabulimia, compared to only about a quarter of them without any history. So checking and screening for eating disorder, either prior to diagnosis and periodically through treatment, is really important. Okay, I've shared this example before. This is a portion of the Eat 26 screen. So it's a validated tool that we use to screen for eating disorder behaviors. Now, you can quickly kind of read through this. What I'm doing today is highlighting a few different things. So the one in red, I'm terrified about being overweight. This one's in red because, again, if we go back to that slide with those pillars where I threw that, weight in red over, if our encounter with those patients newly diagnosed is focused on weight, we may be inducing significant fear about being overweight. Okay, so this is where our role and our language that we use is really, really key in terms of how a person views their body, okay, the size of their body and where they're at with their weight, as either just kind of there and neutral in terms of their diabetes management, or in a really negative light. Now, in terms of the stars that are yellow, these are essentially direct symptoms of what we educate. Okay, so being aware of calorie content of foods, we teach label reading, right? We are making sure people are aware of the calories and carbohydrates in their food. In terms of burning up calories, when I exercise, I'd switch calories slightly to carbohydrates. We often educate, you know what, if you're not on insulin, and or even if you are, if you have a really high carbohydrate meal, you can go for a walk afterwards to use up those carbohydrates. So same with, avoiding foods with sugar in them. Number 16, eat diet foods. 17, number 19, display self-control around food. These are things we educate people on in terms of diabetes management, because we're trying to make them aware of what's in their food. And sometimes that can almost become hyper-focused for them. Dieting behavior, again, encouraging people to reduce their glycemic load, encouraging them to label read and choose a better product is dieting. Okay, it's a form of restriction. Asking them to reduce how many sweets they have is a form of restriction. Okay, now the stars that are in green, these are typically comments and symptoms that I often hear from the clients and patients that I'm seeing who live with diabetes. So avoiding eating when I'm hungry, right? If it's between meals and they don't want to take extra insulin, they may just skip that meal. Preoccupation with food. Hear this all the time. It's all I think about. How many carbs are in this food? Can I eat? When was the last time I ate? Do I need to check my blood sugars afterwards? Eating binges, this is not all the time, but frequently. So if people are quote unquote good all week and they go to a social event and they kind of say to heck with it, and it's like an all or none mentality that sometimes education can create. Number 10 is a big one. You probably hear this all the time. They may not come straight out and say, I feel really guilty after I eat, but they may start their conversation of, oh, I was bad this weekend, or I was bad on my vacation. Okay, so that guilt is present, and it's often present. A lot of people will tell you when they're visiting for an appointment, I know I shouldn't have eaten that. That statement right there is their way of saying, I know you've told me this isn't good, or I've learned that this isn't good, maybe online, and I did it anyway. Ugh. So we want to hear these comments that they're saying. Control around food, feeling that food controls their life. If you ask a person who lives with diabetes, on insulin or not, how often they think about food, I think you'll be really surprised how much time they're spending in a day trying to balance their intake with their blood sugars. And same 22, very similar in terms of number 16, around feeling uncomfortable after eating sweets. It's something that we've highlighted as a potential cause of their diabetes. And so it is a very fine line for them to walk around minimizing how much, controlling blood sugars versus feeling negative and guilty if they eat those foods. Okay. So I'm hoping after looking at this, you're probably thinking, okay, how am I going to have these conversations that I need to have around diabetes management? So let's go through. Let's look at some of the warning signs. Now, the continued focus on food is a critical piece of diabetes management. We know that, right? So this aspect actually makes it a little bit trickier to see the warning signs of people who may have disordered eating with diabetes, right? Because is it a normal behavior that is encouraged to manage diabetes, or is it disordered? So let's look at the warning signs. If you suddenly have somebody who is less focused on their care, maybe the first few months they came in and they had all their blood sugars and, they were tracking their intake, etc. And suddenly they come in for their follow-up appointment and they haven't taken any blood sugars. Okay, consider that a yellow or red flag. If they are sometimes hiding their diabetes management, maybe they aren't as comfortable to do their insulin injections. Maybe they're not as comfortable checking their blood sugars after a meal, especially if they're in a social setting. Maybe they don't want other people to see their blood sugar reading. Any fear of impact of medications on weight. So again, depending where we've labeled the importance of their weight in their management, this may be a really key piece. Or if weight has been a concern for them prior to their diabetes management, they may be very resistant to medications, especially things like insulin. They may also be very adamant about getting diabetes medications that do induce weight loss, like Ozempic. So think of that also as a potential yellow flag if they are suddenly very resistant or very eager for certain medications. If you're seeing unexpected loss in a patient or client with diabetes, I know sometimes it feels like it should be something that's celebrated, but please be mindful that they may have resulted or resorted to absolute restriction. They may be omitting insulin. They may be engaging in very unhealthy behaviors to have achieved that weight loss. If we turn around without asking and say, whoa, look at you, you're down 20 pounds, high five. We've just encouraged those very dangerous eating disorder behaviors. We've reinforced to them, even if they're struggling significantly, that they need to keep doing that because that's what we value. Okay, weight fluctuations. So potentially you may see some loss, maybe some significant gain and loss again. They may tell you, you know what, my weight is up and down. And again, we really want to look at that in terms of, all right, maybe is there some restriction and binge eating going on? Are there changes in their medication that they're not letting me know? What else is potentially happening? In similar fashion, if you are seeing significant blood sugar fluctuations, I had a lovely client who finally did acknowledge that they were binging in the evening and oftentimes not taking their insulin. So we would see these significant spikes in their Libre throughout the night and then well controlled through the day, but actually wasn't well controlled during the day. They just were restricting. So really checking in terms of patterns and asking them, in terms of what's going on with food, with medication, with meal timing to see what patterns are coming out. And medication irregularities. What I mean by this is if they are refilling their scripts too soon or not regularly enough, is a really good way of knowing whether they are taking their insulin and or their oral medications or injectables. The sudden request for Ozempic, I did want to spend a minute. I could probably spend another half an hour on this topic. Ozempic can be a fantastic medication for people with diabetes. I think the key part when it comes to disordered eating, we have to acknowledge the fact that a side effect and one of the quote unquote benefits of Ozempic is it induces anorexia. So there is a fine line for a person if they've really been struggling with binge eating or feeling hungry all the time, where it can be positive for them to be able to breathe, if you want to think of it that way, between eating and be able to think calmly about meals. That's important for some people. For other people who have struggled with their weight but actually been eating well and they start Ozempic and it dulls their appetite to a point that they're barely eating 1,000 calories a day, that is a concern and disordered. And if, again, we encourage that, hey, you've lost 10 pounds on Ozempic, high five. Maybe they're eating 2 meals a day and it's enough for a 5-year-old. Again, we're reinforcing the fact that they are starving. So it's just really something that we need to be aware of as care providers and really have time to have those conversations and ask those questions. So how can we support these people without harming, right? So we went through some of those red flags. We talked a lot about standard in terms of diabetes management and support. And so how do we now take kind of these very risky education pieces and knowing there's a high potential of those people coming through our door that are going to live with disordered eating? This is one of the most important pieces, and it is, especially in the obesity guidelines. We need to ask instead of be telling people how to manage. Taking 5-10 minutes up, ask how they're eating, how they're moving, how they're sleeping, how their stress is, and asking how they think they could best manage their diabetes, right? We give them the education. This is sort of the things that we know. How are things going for you? What would be doable? That empowers the person themselves to know what they can do and know that they can do something, as opposed to us saying, hey, you need to go lose 15 pounds. Very different mindset. If we are going back to that statistic of at minimum 12% to potentially 40%, if we assume that almost half of the people coming through our door with diabetes may have disordered eating, that already lets us know that we have to be really gentle with the way that we are delivering diabetes information and also be screening. There are validated 3-question tools. SCOFF is in, I think, most EMRs as well, and we'll talk about that. If we go back to that slide in terms of diet, exercise, stress, sleep, medications, we can present that to people who are living with diabetes. These are all the potential things that can impact your blood sugars and your diabetes management. Which part's most important to you right now? They may not have capacity to change their diet right now. They may have a very low budget. They may hate cooking. There's a million and one reasons. They may live with significant pain and injury and may not have a lot of room to increase exercise. Medications might be key for them right now, and that's okay. We need to normalize that part, and we need to normalize what is doable for them and be really supportive of that. Really important, not just renewing medications, but checking in when people are in to see for follow-ups of how is the medication going? Are you taking it? Are you having side effects? Is it working? Right? So we want to ask those questions. If they're open enough to say, yeah, I'm not taking it, we want to ask why. Why did you stop? Well, I was, having a lot of digestive issues. Great. Okay, we can address that. If it's related to weight, we need to be respectful and dig a little further into why they have such strong concerns about their weight. Is there a different medication or option that we can look at to support their concern? Again, I can't emphasize that slide again. If we can use language that focuses on the lifestyle pieces, weight may very well change if lifestyle is what was impacting their weight. The piece that's important, so in the guidelines, we know 5 to 10% weight loss for some people can make a significant improvement in their diabetes management. What we don't know, when we just look at that number today, right, this slice in time today, hey, today your BMI is in the overweight category, you need to lose weight. We don't know if maybe they've already made lifestyle changes and maybe they're already down 20 pounds and they've already lost their 5 or 15%. So we want to ask first if it's okay to discuss weight. If weight is even a concern to them, they may feel fantastic in their body. We're not going there. But we want to look in terms of, are you eating okay? Are you moving okay? Are there other things you'd like to do for exercise or movement? Are you feeling okay with the level of stress you have? Do you think it's impacting your diabetes? Do we need to run through the diabetes distress scale? What supports can we find you? And again, if you are going through these stages, if you're going through these questions, if you're seeing a lot of red flags come up, it is so crucial to have that open conversation. You know what? I have a little bit of concerns that maybe management of diabetes is creating a little bit of disordered eating. Would you be open to other supports? Would you be open to seeing a social worker? Would you be open to seeing a dietitian? Would you be open to seeing whoever else? The diabetes distress scale is sometimes a pretty neutral scale to use because it's focused on diabetes as opposed to disordered eating. Whereas the SCOFF scale really comes in more as, are you scared to gain weight? Has your weight gone up 1 pound, etc. So both of those good tools to use and start with, and then already having potential options in terms of referrals so that it's a quick and easy turnaround for them. Okay, so if there's any questions, please anyone feel free to shoot me an email. I've put my email up. And I have some of the key studies that I used and referenced if you'd like to see them. Otherwise, thank you so much.
Thanks so much, Jenna, for that presentation. I just want to highlight that if you want to watch any of the other healthcare provider webinars that we have done, they are all available at guidelines.diabetes.ca/webinars. There is a link for a survey in the YouTube notes. If you could please fill that out, helps us improve our webinars and lets us know what you want to hear about in the future. You consider becoming a Diabetes Canada professional member at www.diabetes.ca/membership. This will give you a discount to our professional conference, access to our online community, the Canadian Journal of Diabetes and Diabetes Communicator. And speaking of our community, you can continue the conversation about today's great topic at community.diabetes.ca if you are a professional member. Today's presentation was made freely available, so if you enjoyed it and want to support Diabetes Canada, you can do so by making a donation at www.diabetes.ca/donate. And I want to thank you again, Jenna, for providing such excellent education and information on this topic.
Thanks for having me.
All right, we'll see you all next time.